Thank you, Gus and Joe. As I look around the room, I'm seeing a number of folks who have been engaged in one way or other in the Million House Collaborative, and Jose and Ted led to the states. We also had Sarah's been engaged at every step. Lloyd's been at all our meetings. Lynn Coopernil was a speaker from the America's Community Health Plans, Association of Community Health Plans. Alliance, okay, 3 tries. So I wondered if any of you, and Larry, you've been engaged also, I wonder if any of you would like to say a word about something we missed, and then we can open up to questions. Lynn? Great.
One of the things that we found critical was engaging patients by asking them what they needed, as opposed to coming up with what we thought they needed. So we've done a lot of work with med adherence and using community pharmacists, and we do find that to be useful. But one of the things we found most useful was when we asked the patients why they weren't taking their medication, we learned things that we had never thought of. And so one of our plans that is predominantly a Medicaid plan in Portland, Oregon, designed a very simple system that they called My Easy Drug System. And it was totally based like on paper, but the patient, and it used smiley faces and frowny faces, but they found it to be very, very effective in getting patients to be more adherent to their medication. So I just wanted to ask the panel maybe to comment on how patients, members, consumers were engaged in some of the work that you've done in Million Hearts.
You know, I think engaging patients is a key to any medical endeavor. I don't know that there was a major aspect of this. Each of the 3 community health centers sort of did things a little bit differently in terms of how they engaged their protocol, but certainly talking with patients, educating patients. I think the home blood pressure piece of it probably was an opportunity to do a lot of what you're talking about, because someone would go into the home, a community health worker, and not a medical person, and sort of be able to engage the patient better. But you're making a good point. That's got to be a part of any project like this. Is ultimately it comes down to the patient and why aren't you taking your medicine, or what's your Maslow hierarchy looking like today, and how can we work on that? Yeah.
You know, I think from our standpoint, it's that education piece also. People generally with hypertension don't feel bad necessarily, especially early on. And so they don't oftentimes understand the importance of taking this. So the educational piece is big. Also, again, it's that sharing of data. As I said, the physician writes it. And I will tell you, patients aren't often coming in and saying, I'm not taking it. And what happens is a clinical decision is made based on the fact that whoever's treating the patient thinks they're taking it, and they'll change medications. We see that in the diabetes area over and over and over. And so it's that accountability, getting what's filled. And so I think it's really kind of a multifaceted thing. And then asking them, like you said, why aren't you?
I mean, the other piece is to ask them, what are you taking? Bring your pills in with you, because it's amazing sometimes what you find that they actually are taking.
Right.
More than, or stuff from years ago. It's amazing.
So I just want to reinforce one point. We'd like to highlight innovations, and we are all talking about these electronic health records. You rarely hear innovation like Lynn just mentioned, paper, and it worked.
Paul, I'd like to actually follow up your comment with an observation from watching the collaborative over time. And it may be pointing out things that are so obvious we don't talk about them, but what happened changed how we think about how we work together. The collaborative at the beginning was a crazy idea to see if it could happen, and in fact it worked. And I think what we've learned is that you can come together in teams and work together, and the meeting that we're having here would not have happened if this hadn't worked. So I just want to call out that how much has happened because of the work of the collaborative and the sharing, and that I think that in fact may be one of the key lessons of the collaborative is when we do come together and share, we can do things we never thought were possible. So I'd like to thank you and the group for taking that on, because I think we've all learned from it.
Great panel, and I just have a quick programmatic question. Are there any lifestyle interventions associated with this? And if so, what are they and how are they delivered? If not, why was the choice made not to do lifestyle interventions when that's also evidence-based?
Yeah, there were, and I'll get started, and Sharon, if you're still here, may fill in some. So a number of the states were using the Stanford model of self-management to roll out, and for those of you who don't know that, it's Kate Lurig's program. It is a evidence-based program that is about patient, and I want to use the word patient, individuals' self-efficacy around their condition. It's been studied down to the 5th grade level. It's been studied as English as a second language. It is a highly effective program. So a number have done that. Others were doing community interventions around cooking classes, shopping, and you can go to a Safeway sometimes, and one of their nutritionists will take you around. Others were using DASH diets and things like that. So there was a lot of outreach into the community around lifestyle. And then one of the faith-based organizations, particularly churches, because if they can change the foods at the church, if they can change the way the church engages, that's a major, in some communities, social connection point. So I don't know if anyone else is here that wants to add any others.
So was that part of what New York did or not?
Jeff, I'm not sure.
Okay.
I think there was certainly, I don't know whether we used the Stanford piece of it, but we did,
Right.
we did work on that. Another thing I would add is farmers markets and other
Right.
sorts of activities like that. It's definitely part of what we're doing.
And so as you're looking at the data across the program, are you able to do any comparative effectiveness analysis?
Within us, our three
Or
sites.
across the entire
So
Million
this is
Hearts?
one of our biggest frustrations with initiatives like this. The same was true with our Healthy Babies that Mary talked about in the COIN, or the prescription drug interventions, where different interventions, policy interventions occurring in different states. We cannot find anybody to study those things. For the Healthy Babies, I went with Jennifer House from the March of Dimes and met with Alan Guttmacher at the NIH and said, can somebody help study these different interventions and the answer was the same answer we got from everyone else: we don't do that. So someone in academia, Larry, needs to figure out, is there a science that can study something as messy as policy change?
Of course it
And can it be done in a way that's rapid to inform what we're doing? We haven't come across such a party. But maybe you can do it, Jeff.
Well, but this isn't necessarily policy change. I get, and that can be studied, but even within the four walls of Million Hearts, you're doing different, the nature of the intervention is different in different communities, and it would seem to me it's in CDC's interest as the funder to want to learn which of the approaches was the most successful, and therefore which ones should be scaled.
Hi, Kate Perkins. I'm City Public Health. We're a public health institute based in Augusta, Maine. I have 2 questions. My first question is about the blood pressure management. iPro, for example, in New York State is very active, simultaneous to your Million Hearts, in attempting to improve the accuracy of blood pressure management. And I'm curious if you have any observations or information about the extent to which improved accuracy in blood pressure management blood pressure measurement may have had any impact or implications for your prevalence assessments, because IPRO is mostly dealing with the CMS pieces initially, but it is statewide. So that's question 1, then I'll pause.
I'll say 2 things. One is that there was never at any point an attempt to say, we're doing the work here. It was much more find out who else is doing the work and work with them, because you want to create a movement, engage everybody you can. But secondly, we did find a number of things. We found that many clinical settings don't calibrate their blood pressure cuffs or equipment, and so there were initiatives to help support that. Secondly, the protocols specifically dealt with how do you take a blood pressure, and that was the biggest problem in the clinic as it was the fire department of the church. I mean, how many people here sat for 10 minutes last time they went to the doctor's before their blood pressure was done? Never happened to me. So, a lot of work around both the calibration and the recording of it.
Yeah, I think we did, that was part of what was done as part of the protocol at these sites. I'm not sure if we used the iPro, whether they contributed to that piece of it, but that was definitely part of how you get set up, yeah.
But did you differentiate in your case finding between people who simply had blood pressure measurements in the past and hadn't been identified or diagnosed with hypertension, and the extent to which accurate measurement may have predicted that versus inaccurate measurements previously?
Yeah, I don't think we did, but that's a good question, yeah.
So my second question is about Million Hearts in rural areas, because large parts of New York and Oklahoma are rural. To what extent are you building different shoes, I love the analogy, different shoes in different places for how you implement it, because whether it's 1305 or any of the other initiatives, how you do it, it has to vary.
So I think
You're not on.
there. They're doing this intentionally to me. So we did not prescribe what people did. We said, look at your how the blood pressure taken, look at the algorithm guidelines, things like that, but we didn't tell them which one to use or how to use it. Most of these settings included a very significant, if not exclusively, rural environment. So we had Vermont, New Hampshire, Alabama's rural environment. I think in Minnesota it was not an urban environment. So a lot of the work was done there. And I'm hard pressed to think of an urban environment that was taken on, but we'll have to think about that.
Well, I mean, we weren't in New York City, but in the Albany site, that was basically an urban, serving an inner city type of population. Yeah, so we just had one truly rural site. I'm not sure, there are lots of different things about that site. I don't know how much of them relate to it being a rural site. I think the message is, if you're going to expand this and go more broadly, you have to go through the same process with the new sites. It's not like you come in with here's the format, just follow this menu. You really have to go through the process again of getting the buy-in, getting the stakeholders, getting the contribution, seeing what the resources are in the community, getting the right people at the table is a key step at the first place. And there may be some generalities about the differences in rural areas, but I think it's really going through that collaborative process to get yourself going. And we can clearly jumpstart that based on our effort, but I don't think you can bypass it completely.
Yeah, I would echo that. Really, the way we start any program, whether it's rural or urban, is we get all participants at the table to begin with. And historically, payers would go out to providers and tell them how the program would, or basically tell them what they need, instead of asking them what problems they have and what do you think you need. And so we get a lot more buy-in, and that's what allows us to have some similarities and some differences in different rural communities. That's the best thing to really align incentives and strengthen your relationship. And I think that's what we've done, and it's worked very well for us.
Ted Winslow, former director of health in Ohio. So when I went to my staff with this proposal, they said, sounds like a good idea. When I told them the timeline that you put in, they almost fainted. So I had to resuscitate my staff and get them around this new definition of measurement that you're bringing forward. So my question to you is, now that we've been through this and I guess everyone survived, what did we learn from this as we go forward? Should we expect to see more of this type effort with tight timelines looking for quick responses, or does it have to be applied in specific settings so that it's only useful in certain situations? Because public health is not used to this. So give us some guidance on this.
Yeah, I think one way is to look at this is we picked a topic where there was a lot of interest to drive an intervention and a change in how we do work. And it happened to be hypertension this time. It could have been something else. And hopefully, but by doing it this way, we're introducing that, the necessity for the leadership to set programmatic and policy initiatives to drive it with rapid cycle change, develop measurement systems to drive action, not look for a perfect system or one that reports data 6 years old. This was really an intervention to change that whole thinking. And also on the clinical side, how do I work with public health in a bigger system here? How do I spread from one clinic to many? When I was with Kaiser and other community health plan, other HMOs in the past, so always a nonprofit side. When I came to public health, I was totally flabbergasted that you got a year to write a plan and then 2 years to implement, instead of just making mistakes and correcting as you go. And it's not just public health that does it that way. I think, a lot of clinical work you don't have action first. But so I really hope that this experience is going to change how we approach some of these things. My impression is that the health officials, the chronic disease directors, certainly the CDC, the Million Hearts program, and as well as our community partners actually like this notion. And frankly, it works a whole lot better to do a small test of change rather than write a plan and dump it on the whole state and say everybody's changing tomorrow.
Yeah, I would agree. I think we need to really take what we've learned from this and apply it more generally in public health, because this is a different approach. You're right. People were scared, didn't think we could do it, but we did, and I think we've got to, publicize that, say what made it work. I don't think we can gloss over that some resources are put into the coordination piece is critical to making it work. It's not something that's going to happen, organically without effort being put into that, making the collaboration actually function. But this is a new way of doing things, and we got some results. So let's and I think from CDC's point of view, I'm sure Tom Frieden is pleased that something happened in a short time frame. We're constantly looking at old data and saying we can't really change the needle on things, but this is an instance where we did on a very narrow, specific question. But still, I think it's a model for what we can be doing.
Yeah, we've also been told the secretary's been briefed regularly and is very happy with this. But yeah, the other major change is moving from collecting data for historical reporting purposes, basically becoming infomorticians and embalming our data, and collecting good enough data to drive action. Very different approach.
Yeah, I will tell you this, this approach for all of y'all that want to partner with private payers really appeals to them, because they don't like that several years before you see an outcome, because they want an ROI in 18 months. And so it really meshed, and it made it very easy for me to get buy-in all the way through corporate, because it had some tangible goals and it had some expectations. And even though they were lofty, I think they were good, and it really meshed with the private business model, which I think is different than perhaps the public health world.
Hi, Ron Bialik with the Public Health Foundation. Thank you for sharing so much about this really impressive initiative. It's great to hear. And I'm curious about how you may have addressed clinician perceptions and attitudes. And for instance, a few years back, we were working on an asthma initiative around asthma management and control, and had clinicians and public health professionals and researchers and community members and others at the table. And frequently, there was the comment from the clinicians about the non-compliant patients. And it wasn't until the community members started talking about the choice between putting food on the table and purchasing meds, the inability to take time off from work because of no sick leave, self-esteem, et cetera. It wasn't until those discussions took place that the clinician said, oh, they're really not non-compliant. There's something else going on. I'm wondering how you may have dealt with that within your initiatives.
One of the things that we had to deal with early is similar to that, is the fact that when you're going into somebody's practice and you're saying, we're wanting to extract these people and put them in a very defined arena to watch their blood pressure, check their medication adherence, that causes a lot of indigestion in practices, and it really puts up barriers. And so by bringing them to the table, bringing data that we have and say, here is your patients that have had some hypertensive medication in the past, here's how many that we can show you aren't getting it refilled. Whether you stopped it or not, we can tell you either somebody's giving it to them, but they're not buying it, because we would have that record. And that really opens their eyes. And so it's by, again, telling them, not telling them what you're going to do, it's saying, how can we help improve your patient's blood pressure control? And I think that was easier for us, at least in rural communities, where most practices are independent, they're independent thinkers, and at least in the state of Oklahoma, they don't like being told what to do. And so that's really what's played well for us.
Yeah, I think in our case, we overcame that hurdle partly by how we selected the sites. These were federally qualified health centers. I think the leadership in those centers was key to this whole effort. But I think these were not new concepts, I don't think, to this set of clinicians. And so, yeah, you do have to sort of bring people along. But I think we had a good group, maybe not a completely typical group, and that may be an issue that as we expand and go further, we need to really think about how we deal with that.
I think the approach is also important. The old approach of basically informed, well-meaning providers can do a good job, and when you turn it around that good job's not being done, the flip side of that is you must be bad providers. Or the non-compliant patient where we're going to work on health literacy. Well, they're illiterate. No wonder they don't follow. You know, that's just a wrong approach. So the notion here is everybody's trying to do the best they are. The patients, the docs, it's about the system. And how do we fix the system? And is there any way that if we're finding, 10 or 15% of people in your practice with elevated blood pressures on visits and they're not diagnosed, that's a non-compliant patient? It's not a bad doctor either. The system didn't catch it. Or if 50% control, could anybody really argue that if half of their patients are non-compliant? I mean, we can get better. And I think, yeah, there'll always be non-compliant patients, but maybe that's 5%. So let's work on the other 45% that we aren't controlling now. So I think it's a non-defensive way, and looking at the system is blameless, as opposed to the old, well, if you were only up to date on JNC7 and were motivated and acted, did the right thing with your patient, then they'd be in control.
Before we leave that, I just want to say one of the things and the approaches that we take when we roll out any value-based care program is we meet with people and we say, let's make sure we have our number one focus aligned and what is best for the patient. And we get that established that no matter what, we're going to do what's best for the patient, not what's the cheapest, not what makes you the most money or saves us the most, what's best for the patient. And I think setting that goal and that expectation really goes a long way to get buy-in regardless of where you are in the spectrum of delivery.
Martha Gold from City College and a member of the Roundtable. So it's exciting after 30 years of looking at all the people who are undiagnosed and all the people who are uncontrolled to see sort of a Herculean effort being put in this direction. On the other hand, I'm thinking a little bit about Gil Welsh's book about overdiagnosis, and I'm thinking about the different ways that people identify people who are hypertensive. So 2 readings in a doctor's office and white coat hypertension, what do you make of that versus Vermont, go to the library, take out the blood pressure cuff, which sounds fabulous. It seems to me that you must have a very heterogeneous way of diagnosing hypertension, and I wonder about this whole notion of sort of looking under the lamppost and, this being the medical model, here's a number, we can treat it, here's a pill, and whether that sort of derails us a bit from some of the sort of primary prevention kind of work that we want to do. So here's your challenging question for today.
Well, I think it's a very important and good question, and there was a lot of work going on in the communities about identifying people in the community with fire stations, faith-based organizations, and referring them in. And optimally, your hypertension protocol would include that period of assessment, a trial of diet or activity change, lifestyle modification before you got to the treatment. I think NQF 18 is also 140/90, so it's not, it's not draconian in terms of who's in control or not. But there's certainly maybe people who are overdiagnosed, but our biggest problem, I think, is the 50% with a diagnosis who aren't controlled. But it's a good point. We really don't know how. There was the farmers markets, things like that were done, but in terms of getting into affecting the food supply in the country was a little bit beyond us, especially in 10 months. So, but good point, Martha.
Sandy Magnan from ICSI in Minnesota. So my question is, what advice, based on your collaboration, would you give to ONC, the Office of the National Coordinator on HIT? They've put out a 10-year vision that they're trying to build interoperable HIT. It looks like it's among many partners, but includes public health and the clinical systems. What advice would you give to them based on what you've done, which included a lot of HIT, and you uncovered some things that aren't so pretty? But what advice would you give to them as they embark on this 10-year vision?
So one thing to say is that their vision that they put out, I think, does involve public health more so than in the past, and that's historically been a real problem, that public health has not really been at the table. So yeah, I think it's really building in the population health view into electronic medical records or electronic health records systems. So the ability not only for the provider to look at their practice, but also to be able to look at it at a population level. And we tried to do that in our one Rio And the problem we found was that some were reporting transactional data. Actually, 80% of what was coming into that RIO was sort of more transactional data, HL7 messages, which you really couldn't turn into a measure of hypertension or registry, and only 20% were putting in clinical CCD documents where you could actually look at diagnoses. And so the system has to change so that the data that you need are actually being aggregated at the regional level, a population-based level. So that, from a public health point of view, it's great that the provider is able to manage their patient population, but we at public health also need to be able to look at a population view, and that means we're never going to have one EHR, but the EHRs that are out there need to be able to produce documents that we can then use for population health.
You know, I really agree wholeheartedly. I think you answered the question. If I just had one thing, it's, and I'm from Oklahoma, I don't like anybody telling me what to do either, but, you know, we have to mandate interoperability, and with that will come a drive to lower the cost to do so. If you look at these large EMR companies, there's a significant upcharge for sharing of data. I mean, geez Louise, a very large one that all of you know, you can have two versions, two of the latest versions, they don't even talk to themselves. Now there's a buy-up to get it to talk to the neighbor across the way, but again, it's interoperability, and it's demanding that you don't have to be on this platform, that you have commonality, that you can share that data with anybody that's participating in an HIE or RIO or whatever, and it's mandated for you to play.
I think the other thing I would say is to build in the reverse flow of data, like I was mentioning with, you know, prescription fills. How does that get back to the provider? That we not just talking about aggregating data to the population level, but also feeding data back.
I guess, and I'm not going to pretend to be an expert in EHRs, but yesterday I gave a lecture to fourth-year medical students at Georgetown, and I asked them how many of them throughout their 4 years had ever been in a practice that used a registry to manage patients. Not one. So there is one. There, the family practice residency does have one, but frankly, that grant from HRSA is ending, and they're going to have to get rid of the registry manager in a year. So there's not a business case here, and I think that's the problem. The business case for EHRs is driving capture of claims and basically improve billings and claims things. I'm maybe a little cynical, but there's not a business case. People buying these things are not buying them for their registry function or their ability to improve population health. And I'm sure there's some exceptions in the room here. So if the market isn't supporting that, we either have to change the market more quickly, which hopefully the SIM grants do, so people have a demand for tools in the EHR that will support population health, or it has to be mandated in a certified EHR. Because I mean, I remember years ago talking to the vendors, and they'll say, oh yeah, I'd say, show me all my diabetic. Oh, I can do that. And then 20 minutes later, they're still going like this, and nothing's coming out. It needs to happen like that. So somehow we either change the economics or we mandate it, but it's got to be there and as a tool for docs. And I'd say that's probably the most important thing that we can do. It is so frustrating to be sitting in the meetings and everyone's saying, oh, we have an EHR. And then we find out that means nothing. It doesn't help them manage their patients at all.
That's exactly right. When you look at the data, at least the data that we look at, somewhere between 40 and 60% of the patients that a system thinks is their patient and stays within their walls go to other systems. And they have no desire. The other thing is getting over this concept that my data, I have to keep it very close to my chest because that's where the value comes. And really the value comes in sharing it. And so we've got to get that through to everybody, and if we can get it through to the systems, I think exactly what you said about the vendors, but we have to hold their feet to the fire.
Yeah, and I want to second what Gus said, is we learned through this that the public health agencies getting access to this data can do some amazing things about hot spotting, identifying, and you know, the population health with a small p, if you add up our three practices and we're practicing the same community, it's still not the big population P. So that's the only the health department is going to come and compare across all these systems. And while we're at it, let's throw in the undocumented, the uninsured.
Hi, Pamela Russo from the Robert Wood Johnson Foundation. I'm going to take a counter view to Martha because, I mean, public health is about preventing disease from occurring in the first place, but it's also about enabling prevention of complications in people who have a diagnosis. And I think you've shown that, really beautifully, because you can do secondary and tertiary prevention that involves, making communities have better walking trails. I mean, that's still enabling people to sort of maintain blood pressure control. That's not separate from it. Gus, you mentioned that in some of your practices, or in some way, you were integrating both the hypertension and the diabetes and DPP. So I'm really curious how that worked, and then also on the registry side. So what do you do when you've got people with comorbid disease? They have to go in 2 separate registries, or what are you doing about that? And then to Joseph, I wish we could clone you and make you the payer face of the entire country. That would be wonderful. I will use your metaphor about claims data and the driving to Las Vegas. That's a great metaphor. And I just didn't quite get, so you're not the only payer in these rural places. So when you go into a practice, and I didn't quite get how it works. The patients come out of the practice, but only the Blue Cross payers, but that's
In the rural markets in the state of Oklahoma, when you combine Blue Cross and Medicaid, we are fairly dominant. And we have an unbelievable working relationship with our Oklahoma Healthcare Authority, and they're our Medicaid entity in our state. And basically, because of the work we've done on the Comprehensive Primary Care Initiative, we have agreed that whatever program one rolls out, the other one will try to mimic that, whether it be in rural or a more urban setting. And so with that comes a lot of penetration into a practice. With CPC, we had one regional payer that's, because we opted for a region, because at the time we applied, the HIE was only really embedded in that region, and we knew foundationally that had to be key. So we were able to take a regional player, us, Blue Cross, Medicaid, and CMS, and the practices that we have treating these 140-something thousand Oklahomans, those 4 payers account for low to mid 90% of the patients within those practices, and that's why I think it helped us get chosen. Because, and again, and I can't remember who said it, but I agree 100%. The more people you get in a meeting, less gets done. I think that was Mary. But I say that every day of my life, and it was much easier for us with just 4 payers. As a matter of fact, these are 3 payers that get along with each other very well. Not that we don't get along with CMS, it's just they're not our neighbors, if you will. They're very good people that stuck in a terrible bureaucracy sometimes. And so we're able to drive things like we mandated before we were chosen, and I put it on my application. I said, don't even consider us unless every single payer participates in this HIE. Don't even do it, because we're not going to go. And it's just the way that you can collaborate. Again, putting patients first and doing things like that, it really breaks down the barriers that exist between competitors.
Just quickly, we're just starting now the work with adding diabetes. We're just now starting the work of adding diabetes and prediabetes. But it's a good point that these aren't diseases in isolation, and a registry shouldn't just be a silo. So that's why the EHR really needs to have that registry function, so that you can cross different diagnoses in the same patient. The registry is not a big database of everybody with hypertension. It's the distributed network that has all the data in it.
So George, power has its privilege. You get the last question, because we're way out of time. So.
Well, thanks for that. So George Isham, co-chair of the roundtable, and in this question, I'm very going to clearly identify myself as being from Minnesota and Health Partners. So a couple of things about this initiative. I had the privilege of serving on the advisory committee to the director of the CDC, Tom Frieden. And one of my first meetings with him, he arranged to take me aside into a room and ask me whether Health Partners would report according to the measures that they had laid out for this. This was at the beginning of the initiative. And I had the privilege of responding that we had just dropped hypertension as a priority in our health plan, because the public health statistics showed that that was no longer in terms of the delta for which we could achieve. It wasn't a big impact that we could do, and our resources were dear, and we had, a list of priorities that built off of the million or so people we insured in the state, about 25% of the population. And of course, one-to-one with Tom in a small room, having a message like that was an interesting discussion. And I certainly am behind and fully supportive of the Million Hearts campaign. In fact, one of the practices that has done very well is a 3-doctor or 2 or 3 doctor family physician practice in Ellsworth, Wisconsin, which was I believe the 2012 hypertension champion for Million Hearts. They and Kaiser Permanente, Colorado, won it that year. And they were a clear example of a family practice that not only knew their community, knew how to use a registry in ways, Tom, that you wish others knew how to do, but also he took me out on the basement and showed me the break room where they had, and then showed me the storeroom where they stored the public health emergency supplies because the public health department didn't have room for it. I thought a very nice example. So my question that comes out of that is severalfold. One, how do we get to beyond a single topic national priority that takes into account the variation in health across the country by region and the priorities that we ought to, beyond states, be looking at? It sort of builds off my question to the folks from Ohio that we ought to be working on. And shouldn't we have a more nuanced set of initiatives that actually is driven more scientifically off of careful epidemiologic analysis about what the priorities are, and shouldn't we be responding to that? I learned from David how looking at those maps of distribution of mortality and other things across the country that these issues are in. So that's my first question. And then the second, we know from experience in Minnesota that the small practice in Ellsworth could do what it did because there were all-payer, all-provider agreement on the protocols. There was training for quality improvement. There was a collaborative, even though they were in Wisconsin and Minnesota, for reporting the data, which fed the registries and so forth. And so for payers, and I now live in New Mexico and serve on the board of one of your competitors in New Mexico, when are we going to get them all to work together on the private side to create that kind of collaboration beyond just, project focused? So those are a couple of the questions. When Tom Frieden came to Minnesota to visit us and figure out why Minnesota was #1 in hypertension control a couple of years ago, he brought the public health folks and the private health people together to sort of discuss that question. It was actually the first time we were all in the same room together. And I took away from that, the conclusion was we had good health care coverage back in 2013 before the reforms, which was a key factor. We had a well-organized, disciplined private sector with collaboration built on common protocols and measures, and we had an excellent public health department and a lot of public health infrastructure. But it wasn't purposeful collaboration. So how do we replicate that in the States?
We're way out of town, and Julie's going to throttle us in a second. So let me just say, great points. Clearly, every child in Minnesota is above average. We know that. You are the model for a country in many ways, and we're learning from you. And in a sense, this was kind of a step back for Minnesota because you already had a comprehensive heart health measure that all the providers are reporting on. So we had to ask you to go backwards and just do hypertension. The rest of the country isn't there. But again, this is just, hypertension was the excuse to build the collaboratives and test this model. If we can learn how to use this model and how to support it, then we could go out and say, okay, let's pick the most appropriate measure in your community or your state. But right now, we're just developing this model and struggling with it. So I know there's a lot more that, in your question, but I don't want to get throttled. So let me just say, in closing, I want to thank our panel members, thank the I really do have to thank the CDC. This was Tom Frieden's initiative, and even though it caused us all lots of angst, it was a great vision that pushed us along. Barbara Bowman was instrumental at the CDC, and Janet Wright from Million Hearts. And then I really have to thank the ASTO staff. It's like having a tiger by the tail, the way they've been moving this thing. So thanks all, and we'll be around to have further discussion.
Thank you, Paul and Gus and Joe. And it really is a great segue. We're going to be a little tight on grabbing your lunch because we want you back in here at 12:45, which isn't very long. And it is a great segue because the conversation we're going to have at that time is about collaboration. So we can build on that question at that time with Paul and Lloyd. I think that'll be a good start for that conversation. That may not be exactly where you want to start, but perhaps you can or build it into that conversation. So if you could quickly exit out here, right out here, and grab your lunch. You can start eating it or bring it back. But we do really want you back in here because it's an exciting conversation we're going to have starting at 12:45, and we want to be sure to give that conversation that full time, that discussion. So it's a quick break for a good lunch, and then back here at 12:45, please. Thank you.
And folks, if you need a place to put your coat or your bags, there's a coat room down the hall. Ask any of the staff. We're just noticing it's getting a little bit crowded in here with people's things. So